Atrioventricular Block EPS. As discussed earlier, the surface ECG-PR interval is composed of 3 intervals. 1. PA interval, also called intra-atrial conduction time. 2. AH interval, also called AV node conduction time. 3. HV interval, also called intraventricular conduction time. Analysis of the His bundle, HB, tracing. Analysis of the HB tracing helps. 1. Identification of the site of AV block, whether it is due to intra-atrial delay, AV nodal, intra-His, or infra-His, His Purkinje system, block. 2. Prediction of progression, for example, marked prolongation of HV interval greater than or equal to 100 millisecond, is associated with a high incidence of progression to complete AV block. Atrial pacing. Normally, with atrial pacing at progressively shorter cycle length, CL, the AH interval gradually lengthens until Wenckebach block develops, AV node decremental conduction, while the HV interval remains constant. If Wenckebach block develops at a pacing CL less than or equal to 500 millisecond, that is, a pacing rate greater than or equal to 120 per minute, this is considered normal response. If Wenckebach block develops at a pacing CL greater than 500 millisecond, this is usually considered abnormal AV node conduction. Differentiation between true AV block and AV block due to excessive vagal tone may be achieved with atropine or isoproterenol. If conduction improves, block is likely due to excessive vagal tone. If no improvement, true AV node disease is more likely. How to conclude the site of first-degree AV block? Intra-atrial conduction delay, prolonged PA interval. AV node conduction delay, prolonged AH interval. His Purkinje conduction delay, prolonged HV interval. Here is first-degree AV block at the AV node, prolonged AH interval of 196 millisecond, normal, 50 to 120. And this is first-degree AV block at the His Purkinje system, prolonged HV interval of 125 millisecond, normal 35 to 55. And here is first-degree AV block at an intra-atrial level, prolonged PA interval, with normal AH and HV. Intra-His conduction delay or block can manifest as 1. Prolongation of H-wave duration greater than or equal to 30 millisecond. 2. Fractionation into multiple H potentials. 3. Splitting into 2 distinct potentials, H, recorded in proximal electrode, and H', recorded in distal electrode. This is a diagram of fractionated His bundle, HB, potential into H and H'. Type 1, Wenckebach, second-degree AV block. Wenckebach second-degree AV block almost always occurs in the AV node, but rarely intra-His or infra-His. Site of Wenckebach AV block. AV nodal, gradual prolongation of AH interval. Intra-His, gradual prolongation of HH', and consequently, HV interval. Infra-His, gradual prolongation of HV interval. Wenckebach AV block at the AV node is shown. There is gradual prolongation of AH until one A wave is blocked, and is not followed by HV, then the cycle repeats. Wenckebach AV block at the His Purkinje system is shown. There is gradual prolongation of HV until one AH is blocked, and is not followed by V, then the cycle repeats. Site of Type 2 second-degree AV block. AV node, A wave not followed by HV. Intra-His, split His deflection into HH', that is, in blocked beats, AH not followed by H'(V). Infra-His, AH not followed by V. Here is Type 2 second-degree avenue block at an infra-His site, one AH is not followed by V. All intervals are fixed. No gradual prolongation of any interval. Complete AV block at the AV node. A waves are dissociated from HV waves. HV association is seen, H waves consistently precede V waves. The escape rhythm most often originates in the His bundle, with H wave, followed by normal HV interval, V wave, and normal QRS. It may, however, arise distal to the His bundle bifurcation, with wide QRS complexes. In these cases, a retrograde H wave may precede the V wave in QRS, or the H wave may be absent. In complete AV block at the His Purkinje system, there is AH association, while the V waves are dissociated from the AH waves. Non-conducted premature atrial beats can mimic type 1 or type 2 second-degree AV block, or 2:1 AV block, if they occur in bigeminy. Premature atrial beats in trigeminy or quadrigeminy can mimic Wenckebach periodicity. Concealed premature junctional beats, failing to conduct retrograde to the atria, and anterograde to the ventricles, can slow or block conduction of the following sinus P waves, and manifest as type 2 second-degree AV block. ECG clues to these concealed beats are: manifest premature junctional beats elsewhere in the tracing. Abrupt, unexplained, PR interval prolongation. Types 1 and 2 avenue block in the same tracing. AV dissociation. AV dissociation is present when the atria and ventricles depolarize independent of each other, each having their independent pacemakers. By definition, there is no retrograde conduction from the ventricles to the atria. AV dissociation occurs with or without block. Causes of AV dissociation. AV dissociation may be due to one or more of the following. 1. Slowing of normal pacemaker activity. 2. Acceleration of a junctional or ventricular pacemaker over the sinus node rate, usurpation, without 1:1 retrograde conduction. 3. Complete AV block. Capture and fusion beats exhibit incomplete AV dissociation. Capture beats occur when ventricular capture by impulses of sinus or atrial origin occurs, as a result of timing relationships between the activity of the sinus node or the atrial focus and ventricular refractoriness. Fusion beats occur when capture beats coincide with junctional or ventricular beats. Differentiation. Two characteristics are required to diagnose complete AV block. 1. Faster atrial rate than ventricular rate. 2. Failure of conduction of all the P waves throughout the phases of the ventricular cycle, even those occurring at long RP intervals. If the rate of the junctional or ventricular rhythm during AV dissociation is only slightly different from that of the atrial rhythm, the standard ECG may not provide a recording opportunity long enough to verify failure of conduction. AV block during atrial tachyarrhythmia. Failure of AV node to conduct during fast atrial tachyarrhythmias should not be considered as pathological AV block, but as normal physiology caused by normal refractoriness. In such situations, terms such as 3:2 or 2:1 AV conduction are more appropriate than 3:2 or 2:1 AV block. AV block with atrial fibrillation, AF. AF with slow ventricular response can be misinterpreted as complete AV block. With complete AV block, the escape rhythm is regular. In AF associated with very slow ventricular response, the ventricular rhythm is irregular. Thank you.